To help keep our patients from falling, we use precautions and put preventive measures in place for all of our patients. But some patients are more likely to fall than others. For those who are at highest risk, we take special precautions and additional preventive and protective measures. If we don't know which of our patients are most at risk, then we can't target our fall prevention efforts effectively. If we can determine which patients are prone to falls, then we can give special attention to them and often prevent the fall. But how do we know which patients are at risk? Who are they? Is it the older patients? How about medication? What role does that play? How about those who are using walkers or canes? According to studies in acute care hospitals, about 2 to 10% of patients fall during their hospital stay. In this facility, we have a falls prevention protocol, so we can more easily target those patients at greater risk for falling. The protocol starts with a falls risk assessment for all patients when they are admitted. The assessment procedure used in this facility is the Morse Fall Scale Assessment. In randomized studies, the Morse Fall Scale has been shown to identify up to 78% of patients who would fall. Why is this number, 78%, an important number? A large number of patient falls are reported as resulting from accidents or from other causes not related to the patient's condition. An example would be a fall in which a patient slips or trips on a bit of water on the floor, or a fall that occurs when a patient catches a foot on a piece of furniture. Falls like these may seem unpredictable, and if they are unpredictable, the reasoning goes, they may be unavoidable. When facilities use the Morse Fall Scale, however, they find that a great many of these falls can be predicted. A much smaller percentage of falls is actually unforeseeable, so many more might be able to be prevented. Users of the Morse Fall Scale consider 3 types of falls. About 8% of all falls are classified as accidents. The rest are classified as physiological falls. That is, they are falls that are related to the condition of the patient. About 14% of falls are related to patient conditions that are not easily foreseeable. For example, a patient who has never before manifested symptoms has a stroke while in the hospital. Because the event was the first of its kind for the patient, it wouldn't show up on an assessment. Physiological falls of this kind are called unanticipated physiological falls. The remaining falls are those that are predicted by the Morse Fall Scale. They're called anticipated physiological falls. So the benefit of the Morse Fall Scale is clear. The main benefit is reliable prediction. The scale predicts a larger percentage of falls than can be predicted by other common methods. The scale predicts the anticipated physiological falls. As a result, caregivers can better target preventive and protective actions. Fewer patients are likely to fall, and those who do fall will be less likely to be injured. In this lesson, you'll see a demonstration by a nurse as she administers the Morse Fall Scale. In later lessons, you'll get a deeper level of detail, and you'll have an opportunity to practice and to check your understanding. This is a med-surg unit at any town hospital. The unit has adopted a new protocol for helping to prevent patient falls. The protocol starts with a formal risk assessment administered by the admitting nurse as part of her initial patient assessment. In this unit, nurses complete a follow-up risk assessment at the beginning of each shift. When a patient is identified as high risk on the risk assessment, the care team creates an individualized plan to try to prevent the patient from falling or to protect the patient if they do fall. In fact, that's the purpose of risk assessment, to identify those patients for whom an individualized fall prevention plan will be required. We'll observe Charlotte, a staff nurse, as she conducts a falls risk assessment for her patient, Mr. Goodman. First, we'll just watch. Then we'll take a closer look at each step of the assessment. Charlotte's patient, Mr. Goodman, was admitted on the previous shift. At the time of admission, the admitting nurse evaluated him as being in the high-risk category for falls. That's why the orange sticker appears on the cover of his chart. This facility uses orange stickers to identify its high-risk patients. Charlotte has reviewed Mr. Goodman's chart. An opportunity presents itself. She gets a chance to observe Mr. Goodman's ambulation.
Are you ready, Mr. Goodman?
Yes, I'm ready.
Charlotte takes a moment to talk with Mr. Goodman.
Hello, Mr. Goodman. My name is Charlotte. I'll be your nurse today. How are you feeling this morning?
Well, I'm kind of banged up and tired. I had a really short night last night. We got here about 9 o'clock, and I don't think I got to sleep until almost morning, I guess.
I'm sorry about that. You know what? Let's see if we can't get you some extra rest time after breakfast.
Well, I sure hope so. I could use it.
Yeah, I bet you can. How have you been getting to the bathroom?
Well, the doctor downstairs, Dr. Rivers, he said I should ring for the nurse and wait to get help before I got in and out of bed.
That's right.
And I've been doing that so far.
Well, you've been handling it the right way. You just need to let us know if you do want to get up. We'll come in and help you so that you don't get hurt, okay?
Okay.
And if there's anything else you need, let us know.
Okay, well, let's talk about your schedule around here just a little bit.
Okay.
They came in at 5 o'clock this morning to take my blood.
While Charlotte and Mr. Goodman discuss the hospital's lab schedule, we'll review what Charlotte did to get a fall risk rating on Mr. Goodman. If Mr. Goodman scores high risk on the assessment scale, the care team will set up an individualized prevention plan for him. If he scores under the cutoff score for high risk, the team will continue to monitor his risk of falling. As long as the score stays low, however, they will rely on the standard prevention practices that have been put in place for the whole unit. So the purpose of the assessment is to decide whether to set up the individualized plan. Mr. Goodman was assessed for fall risk when he was admitted to the unit. Charlotte is conducting a follow-up assessment. On this unit, for follow-up assessments, nurses use exactly the same procedures that they use at admission. The Morse-Falls scale evaluates risk by checking 6 indicators. Now we'll watch Charlotte administer the assessment again and look at what she's really doing. The whole assessment takes about 1 to 3 minutes. It's short, but it has been validated scientifically to produce a reliable estimate of a patient's likelihood of falling. First, Charlotte checks the chart. She looks for any history of falls and checks for diagnosis and ambulation orders. She sees that Mr. Goodman reports that he blacked out last week and fell in his kitchen. And she sees that he has congestive heart failure, so there is a secondary diagnosis. His activity orders show nurse assist. She doesn't see anything in the patient orders about IV therapy. Then she observes the patient. In this case, she can make a direct observation. Charlotte sees Mr. Goodman walking with the nurse aide. She notes that he takes short steps and places his hand on the nurse for support, characteristics of a weak gait. Since this is a follow-up evaluation, Charlotte can look at the previous fall risk assessment, which was completed by the admitting nurse. The check of mental status is focused on one item only. Is Mr. Goodman oriented to his own physical abilities, or does he overestimate or forget his limitations? To score item 6, Charlotte asks him about his abilities.
Hello, Mr. Goodman. My name is Charlotte. I'll be your nurse today. How are you feeling this morning?
By listening to Mr. Goodman's response, Charlotte can see that Mr. Goodman is well aware of his limitations. Notice that Charlotte's check of mental status is different from the standard practice. It is an additional, very specific evaluation beyond the normal check of orientation to person, place, and time. For now, you just need to be aware that Charlotte is looking only at Mr. Goodman's awareness of his limitations. Mr. Goodman knows how he should handle ambulation, so Charlotte assigns a 0 to the last item. Charlotte adds up the score for the assessment. This facility uses a cutoff score of 45 to identify high-risk patients. Mr. Goodman's score is 50, which is above the unit's cutoff score. Charlotte records the score, and that's all there is to it. You can administer the Morse-Falls scale as quickly, easily, and accurately as Charlotte can. To make sure you can handle all the variations that you might run into, complete the following 4 sections of this learning program. In the first review and practice segment, you'll practice decision-making, how to assign a patient to the high or low or sometimes medium risk categories. The purpose of a risk assessment is to determine whether a patient is at high risk for falling. In this lesson, you can learn 2 things: how to compute a total risk score, and how to classify the numerical score as a rating of high risk or low risk. Healthcare facilities go to great lengths to protect patients from injuries. Facilities are designed for patient safety. Procedures are devised to reduce fall risk. The facility staff is trained to monitor patients and to assist them. These prevention efforts benefit all patients. But not all patients are equally likely to fall. Some patients require special attention. Many risk assessment tools have been developed to quantify patient risk. The best tools are those that best differentiate between patients who are likely to fall and those patients who are not likely to fall. They are accurate, reliable, and easy to use. Dr. Janice Morse set out to develop an accurate, practical method for assessing fall risk. Over a 6-year period, the Morse-Falls scale was validated for accuracy and reliability. At the same time, it was refined for simplicity and ease of use. The research team started with a large number of possible indicators that had been suggested over the years. Using a randomized design, patient assessment, observation, and records, the team was able to identify indices that best discriminated between likely fallers and those who were less at risk. The researchers derived a system of weighting that further improved the accuracy of the scale. The scale in its final weighted form produces accurate predictions of the risk of falling. Here are the results of the testing and validation. The scale proved to be both reliable and accurate. It proved to be easy to administer throughout a facility by all members of care teams. It proved to be quick to use. It enabled facilities to have consistency in assessment among all caregivers and from one time to another. It enabled facilities to target their prevention and protection efforts more accurately. In controlled studies, the scale identified nearly 80% of the patients who would fall. This 80% includes not only the patients who fell as a result of easily identifiable medical risk factors, but also those patients who fell in ways that would ordinarily have been classified as accidents. For all these reasons, many facilities use the Morse Fall Scale. It helps caregivers to identify those patients who most need our help. When you use the Morse Fall Scale, you assess a patient on variables or indicators of risk. A typical assessment might look something like this. You total the scores for each of the 6 variables. That's the patient's total risk score. You assign the patient to a high risk or low risk based on this single number. Here, the total risk score is 55, the total of 25, 15, and 15. Let's say, for example, that the cutoff score for high-risk cases is 45 points at this facility. In a facility that is using a high-risk cutoff score of 45, this patient will be identified as being at high risk for falling. This patient will get special attention. Because patient populations differ from facility to facility and from unit to unit within one facility, the cutoff score for high risk can vary too. The training administrator for your facility will tell you the score that is used at your facility or in your department. This is your chance to check your understanding. Imagine that you have assessed fall risk. You've assigned the scores you see on the right. Assume that the cutoff score for your unit is 45 points. Should this patient be classified as high risk or low risk? Click on the appropriate box for this patient. When you're finished, click on the button marked Check My Answer. Imagine that you have assessed this patient for fall risk. You've assigned the scores you see on the right. Assume that the cutoff score for your facility is 30 points. Should this patient be classified as high risk or low risk? Click on the appropriate box for this patient. When you're finished, click on the button marked Check My Answer. Here's an example of the first part of the Morse Fall Scale administration. Watch the example. Then you'll have a chance to practice for yourself. Charlotte looks for 3 things: any history of falling, a secondary diagnosis, and orders related to ambulation. She looks at the admitting history and physical section of the chart and sees that Mr. Goodman fell at home last week. Item 1 rates 25 points. For purposes of the Morse Fall Scale, a yes is indicated for history of falls only if the fall was recent. When patients fall during a hospital stay, the fall is recorded and the patient should be re-evaluated for fall risk. A yes should also be recorded in history of falls if the patient has had a fall in the previous year, as is the case with Mr. Goodman. Charlotte looks for a secondary diagnosis. She sees that Mr. Goodman was admitted as a result of an auto accident where he fractured 2 ribs. He was admitted because of injuries. Also, he has congestive heart failure, a secondary diagnosis. The existence of a secondary diagnosis rates 15 points. The admitting physician has ordered nurse assistance for ambulation and toileting. The doctor's note says, "Up with assistance." There's no scoring required right now, but Charlotte will make sure that Mr. Goodman understands the orders when she talks with him, in order to score the mental status indicator. Charlotte has completed the first 2 variables for Mr. Goodman. The next 3 items on the Morse Fall Scale are related to ambulation. To assess them, Charlotte uses the patient's chart and sometimes observes the patient directly. She is looking for the use of ambulatory aids, for the existence of intravenous therapy or an apparatus for IV access, and for patients who are not on bed rest, she will observe their gait. When Charlotte sees Mr. Goodman, she notices that he is getting assistance from a nurse aide. His activity orders are "up with assistance." There's no indication of an ambulatory aid. Item 3 rates a 0. The score would also be a 0 for a patient who used a wheelchair or one who was on bed rest. If Mr. Goodman had been using an ambulatory aid, such as a walker or crutches or a cane, the rating would have been 15. Some patients use furniture or fixtures to assist their ambulation. In effect, the environment is their ambulatory aid. These patients are at higher risk for falling, so they are rated at 30 points on the ambulatory aid variable. Here's what the use of furniture looks like. Notice that the patient, Mrs. Johnson, makes her way about the room by moving from one support point to the next. And she's not just touching the furniture and fixtures in passing. She clutches each support forcefully. As she comes to a point where there is considerable space between support points, she may lunge or dive to the next. Here, Mrs. Johnson dives to the doorframe as she attempts to leave the room. Patients who exhibit these behaviors will be scored at 30 points on ambulatory aid. Charlotte made another quick observation when she saw Mr. Goodman. When she checked his chart, there was no indication of IV therapy. When she sees him, he doesn't have an IV or an apparatus for IV access, just as the chart showed. So item 4 on the Morse-Fall scale receives a 0 rating. IVs can make ambulation hazardous. They can create a tripping hazard. If there had been any indication of an IV or IV access, Charlotte would have recorded a score of 20 points. Charlotte assessed a third item on the scale just by observing Mr. Goodman. As she watched him walk, she mentally compared his gait to a normal gait. A patient with a normal gait walks with his or her head erect and arms swinging freely at the side. There's not much hesitation in the stride. Charlotte assessed Mr. Goodman's gait as weak. He's stooped, but can lift his head while walking without losing his balance. His steps are short, almost shuffling. And she observed that the nursing assistant is providing little actual support or assistance. When Mr. Goodman gets support from the aide, he is using a featherweight touch, almost for reassurance. So she gave item 5 a score of 10. Charlotte has another patient who has more difficulty walking. She has an impaired gait. To keep her balance, Mrs. Sanchez grasps the aid and furniture for support. She walks with her head down, and she shuffles. Oftentimes, patients with an impaired gait will have difficulty getting up from a chair. They will push on the arms or bounce, making several attempts to rise. The patient you see here, an MS patient, would also be evaluated as having an impaired gait. For this patient, too, a patient who has had an amputation, gait would be evaluated as impaired. The gait of this Parkinson's patient would also be evaluated as impaired. If you see any of these indicators of impaired gait in a patient, item 5 would receive 20 points. Now you have another chance to check your understanding. This time, you'll focus on items 3, 4, and 5 on the Morse-Fall scale. Observe Miss Smith as she moves around her room. Click on the appropriate scores after you've looked for ambulatory aids and an IV or an IV access apparatus and assessed her gait. For purposes of risk assessment, a patient's mental status is an either-or proposition. Either the patient is well-oriented to their ambulatory capability, in which case you assign a score of 0, or on the other hand, the patient overestimates his or her capabilities, or they're forgetful of their limitations, in which case you assign a score of 15. Charlotte has just asked Mr. Goodman whether or not he needs assistance. Here's what he says.
Well, the doctor downstairs, Dr. Rivers, he said I should ring for the nurse and wait to get help before I got in and out of bed.
That's right.
And I've been doing that so far.
Well, you've been handling it the right way.
Charlotte knows that Mr. Goodman has orders for up with assistance. Based on how he responds to Charlotte, he seems oriented to his capabilities, so his evaluation is 0 points on the fall scale. Ms. Johnson's situation is a little different. Like Mr. Goodman, she has orders for nurse assistance. Here's how she responds to Charlotte's question.
Okay, do you need any assistance in getting to the bathroom?
No, I take care of that myself.
Ms. Johnson seems not to be making a realistic response. Based on her response, the evaluation should be 15 points on the fall scale. And that's all there is to evaluating the final item on the fall scale. Either patients are well-oriented to their limitations, or they are not well-oriented or forgetful of their limitations. Here is your opportunity for a self-check. Mrs. Sanchez, whom you see here, has up in chair and nurse assist on her activity orders.
Well, good morning, Mrs. Sanchez. How are you doing?
Oh, fine.
Do you need any help in getting over to your chair?
Oh, no thanks. I can do it myself. I don't need any help.
Now click on the appropriate mental status score for Mrs. Sanchez. Congratulations! Your responses are perfect. You're ready to print your results and take the printout to your course administrator, who will record your score. Your course administrator may arrange a workplace observation with you. A workplace observation is a chance for you to get some help in putting your fall prevention knowledge into practice on your job.